All right. Well, thanks everybody for joining us today. We've got a great talk lined up with three very special guests that are going to be sharing their work with us. This is the first time that we're having one of these talks with more than one presenter. So we will see how today goes logistically, but I from what I've heard, they've done this before and they have a really good coordinated effort in their presentation. So I'm sure this is going to go, swimmingly well. But I'm going to go ahead and introduce them all, and then I'll let them take over. We're joined today by Ted. Now, Ted, I'm sorry. Do I say your last name Berei?
It's Berei, actually.
Berei.
No one ever gets it right. So
okay, so Ted Berei. Ted graduated from Drake in 2014, and he's a pharmacist. He went on to complete his PGY1 residency at North Shore University Health System in Evanston, Illinois, followed by his PGY2 cardiology residency at Abbott Northwestern Hospital, Minneapolis Heart Institute in Minneapolis. After that time, he accepted a role as a clinical pharmacist at the University of Wisconsin Hospitals and Clinics in 2016, where his role consists of caring for patients managed by the Advanced Heart Failure Team and assisting with coursework at the School of Pharmacy. Next, we have Dr. Kathir Balakumaran, who some of you might be familiar with, as he was a fellow Connecticut resident not too long ago. Dr. Balakumaran graduated from the University of Western Ontario and went to medical school at Saba University School of Medicine. Did his internal medicine residency at Metro Health Medical Center and general cardiology training then at the University of Connecticut, where he trained under one of our former colleagues, Dr. Richard Susier. And that experience with Rick motivated him to do a rotation at Yale New Haven Hospital at one point with our heart failure group. He ended up then pursuing training in advanced heart failure and transplant cardiology at University Hospitals in Cleveland, and is currently working at Metro Health Medical Center in Cleveland as a heart failure cardiologist. He's interested in quality improvement initiatives and means of optimizing medication prescription adherence for heart failure patients. And then lastly, but not least, we have Kismet Rasmusson, who is a nurse practitioner who's worked with Intermountain Healthcare as a heart failure specialist since the year 2000. Kismet's a family nurse practitioner with a doctorate of nursing practice and has an appointment with Intermountain as a professor of clinical research. Kismet is a certified heart failure nurse, and is a fellow of both the American Heart Association and the Heart Failure Society of America. Kismet has worked in the Advanced Heart Failure Clinic and as a leader to promote process improvement for heart failure across the Intermountain system for over 21 years. Kismet's special interests include researching peripartum cardiomyopathy and discovering innovative ways to educate and engage patients with heart failure. So as you can see, a great group with varied backgrounds. So this should be a really dynamic discussion, and I guess we'll just go ahead and get started. So I don't know who's taking off first, but please, group, the floor is yours here.
All right, thank you so much for those introductions. So yeah, my name is Dr. Kathir Balakumaran, and I just wanted to segue. So one of the reasons we're giving this talk, this would be now another second time now that we're giving this, and thanks for Dr. Beasley for the invite. We had initiated a group discussion about this on Twitter, and Ted Berei, had actually initiated a kind of a send out. It was anyone interested in collaborating, and that's how this kind of got all started, since we all had a shared interest towards these GDMT clinics. And so we eventually got together and wrote a paper, and we published it in JCF called Implementing Non-Physician Provider Guideline-Directed Medical Therapy Heart Failure Clinics, a multinational perspective, in August 2021 issue. And so this is pretty much a cumulative of that paper in a presentation form. So I'll go ahead and get this started for emphasizing the need for GDMT clinics, which hopefully I can illustrate here in the next few minutes. Next. No, I have no pertinent disclosures for this, so I'll start off with the case This is a 61-year-old male, history of hypertension, diabetes, and Hodgkin's lymphoma in 2012. Had a course of adriamycin with his pre-chemotherapy echo with an LVEF of 58% and a global longitudinal strain around -16%. He did well up until 7 years later when he started having shortness of breath in 2019, and then he was referred for a stress test at that time. And then he underwent the stress test and was found to have a newly reduced EF, which was eventually confirmed on transthoracic echocardiogram and then with a narrow QRS on his EKG. So pretty much typical stories that we're seeing post chemotherapy with anthracycline. So overall, his EF at that time was 30%, dilated around 6 centimeters or so. And he saw a cardiologist within a few weeks after that. It was initiated on Coreg at low dose and lisinopril at low dose to moderate dose with adequate blood pressure and a high heart rate, and really didn't have any other medicine changes for the entire time after that, despite being hypertensive and pretty much high heart rates. So up until pretty much a year later, when he first had his first hospitalization for acute decompensated heart failure, where his EF reduced further and his became more dilated, persistently dilated. At that point, they finally started on an MRA with an aldactone, and his beta blocker and lisinopril were up titrated. So then he followed up furthermore with an eventual heart failure doc in an eventual GDMT clinic. So this is pretty much similar to what we're seeing a lot, where patients are started on therapies upon initial diagnosis, but afterwards they're pretty much staying on the same medicines with no further up titration. Unfortunately, the patient clearly suffered over their first episode of heart failure with no improvement in their EF. So really didn't have a full court press on medicines before deciding if we needed to consider a defibrillator or not. But these are typical stories that we're seeing. Next. So there's tons of landmark heart failure trials, and I just want to continue going next, and you'll see them all pop up. And this is, for over the last 35 plus years now, and we have initiation of vasodilators from ACE inhibitors to ARBs, beta blockers, and over 30 trials up until even like the SGLT2 inhibitors and the omecamtiv mecarbil now. So all this evidence supporting all the therapies that we have, which is amazing for our heart failure patients over the last 35 years. So it's great. And go to next. And there's an incremental benefit to all this. Overall, we see that there is a clear reduction in mortality with the combination of ACE, beta blocker, and MRA, with nearly a 56% reduction in mortality, and now even more so with an ARNI, beta blocker, and MRA, with its nearly 63% reduction in mortality as we continue going up this ladder with escalating therapies. Next. Next. And you can see here also in this particular registry where combination therapies at maximal doses improves the survival in terms of, in this case, in a 2-year mortality on top of their CRT and ICD if they are needing that. So clearly there's a lot of benefit for our therapies that we're utilizing here. Next. This is based on the Paradise MI, which was looking at Entresto in post-MI patients with reduced EF less than 40%. And you can see that initially, before in the era of ACE inhibitors, if we look at our placebo group, the mortality rate was around 30%. And now even like the most common, and this is going back to trials of like SAVE, AIR, and TRACE back in the 1990s with our ACE inhibitors, and then Valiant with Valsartan in 2000s, you can see that the mortality is reduced. And now even with the background therapy of MRA, and ACE or ARB, looking at our sacubitril valsartan group in the one arm and a Ramphel group in the other arm, which were the comparator groups in this trial, the mortality was almost down to 10%. So clearly background therapy is working in our trials, and we've reduced our mortality from 30% to 10% over this time span. So the therapies are clearly working. Next. So here are our players. We have a lot of folks, a lot of medicines to choose from, including the ACE inhibitor ARBs, the beta blockers, your MRAs, your neprilysin inhibitors, your SGLT2 inhibitors, and now your OM or omecamtiv mecarbil, or the vericiguat. So we have a lot of therapies available to us over the last 30 years with all the evidence that's shown to be efficacious. Next. However, I'm sure this is synonymous with any presentation that's looking at heart failure therapies and their poor use. And so this is from the CHAMP-HF registry looking at poor uptake of these therapies in patients who are eligible. And you can see that almost half of the patients that are eligible are on less than 50% of their target dose. And in fact, less than 1% are on combination therapy at maximal doses. So we're still having issues with it, pretty much prescription adherence. Next. And again, this shows in a bar graph form where those who are without contraindication are not treated adequately. So still very low rates around, with some groups of being 40% or more. Next. And this is a Danish registry. And in this particular registry, they looked at real life prescription patterns of their heart failure therapies. And they've shown that usually, if we look at the timeline of when these trials came out back in the 80s and 90s, the uptake of actually prescription patterns was still climbing. And so on average, it took 10 years just for their prescription pattern to reach their peak. So from the initiation of trial to proven therapy to an FDA approval, the uptake was around 10 years to actually implement. And even at that point, the uptake was still low. Next. And this is just a similar graphic showing that even on the patients with the therapies, over time, their average dose wasn't really increasing. They almost stayed static. Next. And then here with the CONNECT-HF, which was showing a post-hospital discharge for heart failure education quality improvement initiative, they showed that although it was a negative trial, the key point that I want to focus on here is that between the intervention arm and your right side, which is looking at some education aspects on top of other quality improvement measures, compared to their usual care on their left, they noted that no matter what, their target therapy on ACE inhibitors or ARBs, RNE, or even beta blockers or MRIs was still low across the board here. And you can see everything was pretty much under 30% acquisition, or under 40%, I'm sorry. Next. So why is it such a slow uptake overall in terms of the medications that we have, despite all the evidence that we have, despite all the mortality benefits that we're showing throughout all the evidence that we have? Next. So there's different reasons. One is the assumption of patient stability, that the patient's doing fine, so no need to increase their medicines. The gaps in the provider knowledge, not knowing what medicines are available, lack of access and coordination of care. From the patient standpoint, the patient adherence, providers deferring to another specialty or another provider, and inadequate insurance coverage, especially when we see newer therapies, and then patient-related factors such as hypotension or renal dysfunction. I'm sure there's more that I haven't covered, but there's so many barriers apparently for us that we need to considerably overcome. So we've come across a lot of drug development, and again, we have a lot of options for our patients, but I think at this juncture, and I'm sure this has been an ongoing thing for multiple years, but I think now the drug development moving towards an implementation science, because we have the therapies. Now, should we more or less try to figure out how to actually get these therapies on board? And so that's where a potential solution would be the next slide, a GDMT clinic. So a guideline-directed medical therapy clinic. Here's a data from, I believe, Australia. Here was a Driscoll. So I was presenting on a low number of patients. I think it was around 10 or 11 so patients. And you can see here in the dotted was your usual care in basically an outpatient clinic. And then on the solid is basically her clinic with her patients, and showing that on a nurse-directed escalation of therapy in her particular clinic in a very quick manner, she was able to get all of her patients to a maximal therapy within 100 days or 3 months. Next. And this is just in the form, the numbers, but majority of all our patients were on maximal therapy in a very quick amount of time. Next. And this is our own experience at St. Francis with Dr. Richard Soussier, who him and his team initiated back in 2017. And here we had all patients coming through our GDMT clinic. And this is just a data of the proportion of patients on any therapy. And for the most part, most of them were on therapy, and particularly a beta blocker. A lot of the patients were switched from an ACE-ARB into an ARNI, where the yellow line is showing after their implementation through the GDMT clinic and the gray line showing before. But what I want to focus more also is not just the therapy that they're on, the actual dose. So next. So here we're seeing maximal doses too. So not only were patients being placed on the therapies more efficiently, but they were actually being up titrated on a higher dose to maximal therapies. And these are the patients who were on maximal therapy by the time they were discharged from the GDMT clinic. Next. So I hope I at least made a case for the need for a GDMT clinic. And now Ted Berei was going to explain about setting it up and the operational considerations. Thank you.
Thanks, Kathir. And a kind of a great introduction into now talking a little bit more about the operational side of the clinics. And before I do go any further, so I did want to mention, so we did have some international co-authors, and I'm sure some of you may have read the paper now, but I also want to give them some credit. We had just kind of compacted the presentation into the three of us just for time's sake, but Paul Forsyth in Scotland, Sherry Koshman in Canada, and then Carol Harshaw Ellis is an MP at Duke as well, but they were also a part of this group. So I just want to give them some credit as well. But I'm going to talk a little bit about the operational considerations to think about when setting up a GDM clinic. Next. Only conflict of interest for me to disclose is cytokinetics. Next. So in terms of talking about, where do you start with these clinics? We'll get more into that as we go along, but really, I think as we all kind of know, money kind of runs the world. So there needs to be cost justification for these services. As much as something might make sense to us as clinicians and providers on the front lines seeing the need for this, oftentimes hospital administrators in the C-suite don't see the things that we see day to day. So numbers speak volumes to them. So with that said, there's a lot of research out there that's already been done looking at cost justification for these sorts of services. And I know, and you guys already may be participating in these sorts of clinics at Yale, but nonetheless, especially in the paper, we tried to go through and cite a lot of this information as well, so that it makes it easier for folks as they're trying to set up these clinics, that they have some cost justification to potentially do this. The other thing too is, especially with pharmacists and having residents, we can have resident-based projects or pilot sorts of clinics as well, where we can hopefully provide some sort of cost justification based on results that we have over a 6 to 12 month period as well. But really what it comes down to is hopefully reducing hospitalization costs, improving quality of life, which I think we all realize is equally important for our heart failure patients as well. And then, just making sure that more than anything, we're kind of showing this from an objective standpoint for when we do go to make that case. Next. So in terms of some of the different clinic models that exist, and as I mentioned, you guys may already be doing this at Yale, but kind of what we ran into from our research and kind of looking not only just domestically, but abroad, what other countries are doing. Really, there's a lot of involvement from nursing, pharmacists, and then advanced practice providers as well. So there's all kinds of different models, and it's impossible to kind of coalesce all of those into a singular paper or try to describe all of those in one place. But just know this is being done around the world, anywhere from even sub-Saharan Africa all the way up to Iceland. There's clinics that we kind of ran into as we were pulling research. So it's cool to think that it's not just in the US that we're able to do these things. It's also all over the world. But more than anything, these are multidisciplinary clinics. So more often than not, they involve not just one of these disciplines, but multiple disciplines in addition to a physician as well. So in terms of the models themselves, so oftentimes you can have a clinic within a clinic. So you may have an advanced heart failure clinic that then has this kind of offshoot clinic that's just looking at escalating GDMT, and that's really their sole purpose. And then there are other programs that have just standalone clinics as well, where the GDMT clinic is kind of its own thing, has its own hours, and it's just operating independently from potentially what the advanced heart failure group is doing, or potentially there are clinics that exist at programs that don't necessarily participate in advanced heart failure therapies, but that do have GDMT-based escalation clinics through internal medicine providers that are sponsoring this, or potentially just general cardiology clinics as well. And then in terms of the subtypes that exist, so telehealth and virtual clinics have become a lot more common, especially kind of during the pandemic and now post-pandemic, if you would consider that. There's been a big shift towards that. In-person clinics still do exist. And then there are those that do offer hybrid situations as well that kind of meet the needs of their patients. So trying to meet the patient halfway, and if telehealth works best for them, or in person, potentially having them come in for visits on a less frequent basis, just so they can at least lay eyes on the patient, but then offering that potential telehealth opportunity as well for the patient to meet their schedule, and understanding that our patients are also busy people. A lot of them are working, kids, etc. So trying to fit this into their schedule and making it something that's easy for them to participate in. Next. So in terms of the leadership of a clinic, generally kind of what our recommendation was from what we gathered is you really should have a singular head of the clinic, someone that is the de facto leader, and that communication will be funneled to for kind of logistical issues and kind of higher level issues. So whether that's someone that is intimately involved in the clinic day to day, or someone that's kind of above that, there should be a singular head for the clinic that is reported to. Most clinics are going to require at least some sort of physician champion. And again, this kind of comes back to, depending on the program, do you have an advanced heart failure program, or just dealing with general cardiology, or potentially places that are just doing internal medicine or family medicine practice as well. You're going to need physician championing and buy-in for these programs, just because you're going to need to have a physician to potentially kind of run things off of, run ideas off of, need labs or imaging, further invasive workup, or just general questions that may come up that the folks running the GDMT clinic are looking for assistance with. You definitely want to have that avenue available for them. And then, thinking about other multidisciplinary groups or teams that you'd want to be involved with this clinic. So I think, like here at UW, for kind of the clinic that we had been running, it got temporarily put on pause just due to some staffing issues, but we had really gotten involved with the general cardiology groups, and then also our internal medicine hospitalist groups here in the hospital, because we were enrolling patients that were admitted, and most of the time we found that we were getting patients from these services rather than our advanced heart failure group, just because those patients were oftentimes requiring higher levels of care, and really needed to be seeing a physician or an APP on a frequent basis for more kind of invasive exams versus just medication titration. So thinking about other groups that you can potentially utilize, and making sure they're aware of these clinics is equally important, because oftentimes they're going to have patients that funnel in to these clinics where your expertise goes a long way in helping these patients out, and giving them the time that they need, as opposed to, as you know, just 15 or 30 minutes in an internal medicine visit or a gen cards visit. And oftentimes certain things are skirted over, or providers don't have time to really think through therapies that may be best for the patient. So that's where these GDMT clinics can shine. Next. So thinking about some of the logistical details of the clinic. So obviously, when is it going to be open? Is it a Monday through Friday thing? You know, if it's a telehealth or virtual clinic, is it just being done a few days of the week in the afternoons, mornings? Generally, we found for a majority of our patients, afternoons oftentimes work better, especially with work schedules and so forth. Where are you going to be located in terms of, are you at the hospital? Is this something where, in theory, you could have someone working from home if you're doing virtual visits, office space, thinking about all of the kind of the minutia, not the stuff everyone wants to think about, but that's going to kind of hold up the clinic getting started and being successful. In terms of resources, what do you need? So not just financial, but in terms of equipment, potentially, again, space, and so forth. How are patients going to get in contact with the clinic, particularly during off hours? Will they be, again, funneled into some call center for general cardiology, the advanced heart failure? How's that going to work ultimately if they're going to be a part of your clinic? So who's going to be available to them in off hours? Who's going to be a part of your clinic team? So obviously we've talked a little bit about, you know, the kind of the key multidisciplinary component team members, but is anyone else going to be involved? Are you going to have an NA involved that's potentially doing vitals? Especially if you're already part of a clinic that exists. So if you're kind of building this GDMT clinic into, you know, the advanced heart failure's normal clinic time with a pharmacist or an APP or even an RN that's just using an algorithmic based approach to titrate medications, are you going to be able to leverage other resources that may be available to that team that you're building the clinic into? And then, you know, I think equally important is all of this logistical information is how are you going to get the word out and how are you going to advertise this to other providers and your health system? So your clinic's only as good as, you know, as spreading the word and getting patients enrolled. If you have no patients, obviously you're not going to be making a difference. So there's a variety of different ways to get patients enrolled. Obviously, those involved in the clinic can, depending on what the criteria that institution determines, would include someone in that clinic. They can go and obviously, like what we do is we pull patient reports here for people that have REF or have PEF. And then we're able to kind of look and see in terms of their level of care, what they need, and auto enroll them in the clinic here in the hospital. That's something that can be done on an outpatient basis too, just going through lists that of patients that are seen in general cardiology clinics or family practice or internal medicine clinics as well, enrolling them, but having some sort of agreed upon delegation with those different teams for how you enroll. If there needs to be approval from the following or attending physician on the ambulatory side, if that patient's going to be eligible to be a part of your clinic, if they need to sign off on it. Kind of what we had done here is we just have a general blanket order for any patient managed by any of our general cardiology or internal medicine or family practice providers that we can auto enroll them. We'll send an in-basket message through HealthLink, letting the provider know that we enrolled them. And then if they have any, you know, questions or concerns about that, or if they just don't want the patient to be enrolled, we can obviously take care of that as well. But ultimately, kind of like anything in life, communication is key. Next, please. So another thing to think about is going to be how do we train the people that are in clinic and make sure that they're up to date in terms of being able to provide the high level of care that we would expect to be provided to this patient population. So again, this is going to be done on an institution by institution basis. And it's also something that probably will vary by state, particularly in the United States, or if you're in the EU, depending on country, and then in Canada, kind of depending on province. But ultimately, different states and different areas have different requirements and credentialing opportunities available for pharmacists, APPs, and RNs. Shameless plug, but the Heart Failure Society of America is going to be, they already have kind of released their HF CERT program. And then there's another iteration of that coming out soon. But that's something to think about too. But more than anything, determining what is the minimum competency that we would expect for these providers in terms of, being able to assess physically the patient, getting vitals, targeted questioning, what is their level of proficiency / training when it comes to their understanding of heart failure, GDMT. And most of the time there's going to be algorithms and protocols that are in place that can help guide clinicians, but ultimately there needs to be some ability for clinical judgment as well outside of that scope. And then there needs to be the ability to interface with the EMR as well. So everything needs to be electronically documented and available. So ultimately it'll come down to the institution, making sure that they're defining what is considered appropriate for them and what is compliant with state and federal kind of law and certification from that standpoint for that specialty. But then from there, it's, making sure that on at least an annual basis, at a minimum, people are staying up to date. So there needs to be some sort of proficiency benchmarking or checking off on an annual basis at a minimum, which would probably involve some sort of shadowing and sign off from another provider. And then also making sure that there's continuing education requirements kind of attached to these roles as well to make sure that these clinicians are staying up to date in the heart failure sphere, which we would expect, but lots of information always coming out. You want to make sure that folks are the most up to date. So something to think about. And again, credentialing looks very different depending on what institution you're talking to and what clinician, what country the clinician is coming from. So there's 1,000 different ways of going about it, but it's something that at a minimum, an institution needs to kind of set a benchmark and then can build from there. Next. Medication access solutions. So again, kind of institutionally varies, but the clinic needs to have the ability to easily determine for patients if meds are going to be covered or not. So some institutions have great resources available either through the pharmacy department, pharmacy technicians, or through other avenues. But ultimately, we need to make sure that we have the framework in place to assist clinic staff with test claims, prior authorizations as they come up, copay card enrollment, insurance enrollment, et cetera. So this is where, again, leveraging resources, understanding what you have available, whether it's through case management, social workers, the pharmacy department, et cetera, and having a clear delineated kind of pathway for how a clinician may kind of go through the process of figuring out if a medication is going to be covered, going through a PA who's going to help them with that. There's just no time to do this in clinic. And it adds on to the burden for the provider to have to go out of their way on their own time to do these things as well, when oftentimes there's resources that exist or resources that could be made available to them to make this much easier and a lot less stressful. So again, depends on the institution. I know a lot of bigger medical centers now have really leveraged the pharmacy department, especially pharmacy technicians that have created their own kind of working groups that you're able to send messages through HealthLink or Cerner or whatever you're using, Epic, and easily communicate with these folks that will assist with this. Or there may be other systems in place at institutions, but it's something that needs to be well thought out, because otherwise, especially with the SGLT2 inhibitors, ARNI therapy, and then starting to move into when you're thinking about SGC stimulators with vericiguat and potentially omecamtiv at some point, you really need to have the framework in place to help providers, clinicians make those transitions for patients easily without having hiccups related to medication costs and so forth. Next. And then equally important as everything we've talked about is making sure that on a consistent basis, we're measuring kind of the success or failures potentially of the clinic so that we can improve upon them. So we've kind of outlined some clinic or some metric musts on here, and I'm not going to go through all of them, but again, from what we extracted, these were common things that folks are looking at on a pretty continuous basis, if not quarterly, at least biannually. And ultimately, these exist to help keep the clinic on track, identify forks in the road that are going to help it improve over the course of time, and ultimately help better serve the patient population. Next. And this is just extracted from our paper, but it's just a quick clinic checklist that can be used for programs getting started, just things to think about right away before you get too deep into this process. And thinking like, are we able to answer a lot of these questions or able to put something together to kind of solve these issues? And if there's a lot of, I don't know, then it's, it's something to think about. In terms of getting a clinic set up, I think realistically, most people would tell you at least 6 months to a year, if not longer, especially if you have to run a pilot, and then getting protocols and algorithms approved through pharmacy and therapeutics committees, and a lot of the red tape that comes with academic medicine, particularly. It can take a long time to see this through, but these are just some general things to think about when you're first getting started. Next. And then I'll hand it over to Kismet for the finale.
Well, thanks, Ted, and thanks, Kathir, for doing a great job in setting up this talk. And I'd just like to say again to Dr. Beasley, thanks for the invitation today to speak to your group about this idea of a heart failure GDMT clinic. I'm just astounded that after the CHAMPS-HF study came out, 2018, 2019, that still with contemporary data, we're still really have gaps in GDMT titration and in our communities, and it really speaks to the need of really creating clinics and producing viable options so that we can do better for our patients, because the life-saving therapies that can really make a difference. I've done a little bit of work with Novartis on video visits. I just wanted to disclose that. Ted spoke about patient recruitment, and I think every clinic or every program is going to have their criteria of what is acceptable for having their patients followed in their GDMT clinic. This is a list of things that you could consider. Those that have a new diagnosis, or maybe those that have difficulty with GDMT titration, may include people with polypharmacy or high comorbid burden. Others may include if they've had issues with adherence or social determinants, which we know is really out there in heart failure. It may include people that have had increased hospitalizations or ED visits, high BNP or high New York Heart Functional Classification. And certainly, people that have planned LVAD or transplant or on hospice would likely not be patients that you would include. And I think, generally the idea would be GDMT for patients with HFrEF is the basic premise that we've been going on for these kinds of clinics that are adults. So when we think about these clinical services, again, Ted spoke about how we can potentially identify patients using chart review, getting the word out with other providers, getting these automated referrals and whatnot, so that those encounters can be set up. And then the rest of my time, I'll be talking about the medication titration, collaboration between the clinic and referring teams, patient and team education, and then graduation from the GDMT clinic. So we all know, we've had really nice slides about foundational therapies that includes GDMT or guideline-directed medical therapy, ARNI, ACE, ARB in one category, beta blockers in another, aldosterone antagonists or MRAs in another, and now the SGLT2 inhibitors. So we have quad therapy for treating HFrEF, and I think this has just been a really exciting few years in the evolution of medical therapy for heart failure. And of course, that includes managing congestion, and that's really the foundation of what we want to accomplish here. We want to make sure that we can get patients on these appropriate meds at target doses as much as they can tolerate them, so that then after we can consider them for other potential therapies, but we need the foundation of medications completed before we think about ICD or CRT or potentially MitraClips. Certainly the newer heart failure medications, vericiguat, omecamtiv mecarbil, and then advanced therapies are typically, not always, but typically thought about after we've maximized medical therapy. In the clinic, we also want to maintain euvolemia. I really like this IMO's pendulum, how it swings between congestion and hypovolemia, and how important it will be to maintain euvolemia as much as possible during GDMT titration. And I think the really interesting thing about our newer medications that include ARNIs and the SGLT2 inhibitors is that they can promote diuresis, and we really need to pay attention to somebody's volume status as we're initiating these medications so that we can avoid dehydration and hypovolemia. This is an example of medication titration plan that actually came to Ted and his team at the end of the slides, and we can provide these to you. There are examples for the other categories of medications that provide information about the initial dose and dose adjustment schedule, goal maximal dose, how we monitor, and the contraindications. What I think has been just really so important in how we approach treating patients with HFrEF is the second expert consensus pathway that came out this year. The first one came out, gosh, I think it was in 2018 or 19, the 10 pivotal issues in treating patients with HFrEF. But this algorithm really nicely talks about the mainstay of our foundational treatments, ACE, ARB, ARNI, and beta blocker and diuretic is needed. And then when we may consider adding or switching the other categories of medications like an aldosterone antagonist, the SGLT2 inhibitors, how we titrate diuretics, adding in or replacing ACE, ARB, ARNI with hydralazine or isosorbide, and when we consider ivabradine. So really nice consensus pathway. As of yet, the US guidelines have not caught up with the US literature, which I'm sure will be happening shortly. They do have some updated guidelines in the European heart failure group that include all of these new medications. What I think has also been really interesting to follow is the evolution of the literature in the last year or so in terms of how we think about initiating and titrating guideline-directed medical therapy. This actually was published a year ago, thinking about our quad therapy for patients in the hospital, to think about administering and prescribing them before discharge, and then how in the outpatient setting we continue titration and follow the patients with labs and maybe perhaps telehealth. And then you fast forward to this year, and this was just published recently, also with more emerging data about in-hospital initiation of quad therapy for patients with heart failure. And we all know that when these medications are prescribed in the hospital, on the right in the green, people are more likely to be treated and to fill their prescriptions and to take these medications long-term. And it really would be a nice setup if these medications are appropriately started in the hospital, or when patients are sent to a GDMT clinic where the foundation of therapies are already started. But again, the nice thing about these more contemporary articles are they talking about how we can get quad therapy initiated, sometimes simultaneously or quickly, titrating all of them over time so that we're not in that clinical inertia that Kathir had talked about, that is just so prevalent and really has contributed to our gap in GDMT titration for our patients with heart failure. I think the only silver lining of this pandemic, really, as I think about it, is the use of virtual care. This is an example of our usual heart failure diary, where we have patients monitor their weight, heart rate, and blood pressure as we follow them in our heart failure clinic. And this is an example, I do have to apologize, it is a very busy slide, but it is an example of a real patient that we put on remote patient monitoring using our electronic platform, so that we could actually follow the patient very quickly and do as rapid as we felt comfortable with GDMT titration. So on the top line represents the patient's weight, on the middle represents the patient's blood pressure, and all the boxes left to right show our interventions. So the initial consult, their drug doses, how we monitored them remotely and interspersed clinic visits with that, but how we were able to really quickly by, let's see, we did the consult in March, and by April, end of April, we had the patient on Coreg 25 milligram BID. But then, the patient started having some low weights, low blood pressures, and we had to do some adjustments based on the biometrics. And, we're gaining more information on how to use remote monitoring. Before the pandemic, the trials were pretty neutral, weak in terms of the benefits of using remote monitoring in heart failure patients. But I think it's really an intriguing idea to think about how we can more remotely monitor patients as we're trying to rapidly titrate our GDMT medications. Of course, we need to monitor labs. There are different protocols out there for how often and frequently you're monitoring labs. Certainly after we add or titrate ACE, ARB, or ARNI, or MRAs, and then after adjusting diuretics. We're also following BMPs 1 week after initiating an SGLT2 inhibitor. So how do we think about these clinics in the context of broader heart failure care? Well, if you have a referral from cardiology and you have a GDMT clinic that manages the patients, there are many ways to slice this loaf of bread, as I see it. We can alternate visits at times with a referring cardiology practice, if that's the way they prefer it. I think being open to different models and what's going to work for your referring teams, is important to think about, versus just, having the patient referred to the clinic and maximize them and send them back whenever you feel like you've gotten as far as you can. But I think we all have to accept the complexity of heart failure, and we all know this, right? That we have different needs for our heart failure patients between imaging and interventions and EP issues, primary care issues with their multiple comorbid conditions and the need for surgery. And so this is a really nice article that came out last year about collaboration within heart failure. And I think it just speaks to the need to keep this in our pocket as we're caring for these complicated patients within the context of a GDMT titration clinic. Also is important to think about contingency planning. I think in that consensus pathway about with all the characteristics of sending for advanced therapies are listed, with other worrisome characteristics that include persistent symptoms, low blood pressure, progressive cardiorenal issues, low cardiac output, and poor hemodynamics, unusual heart failure etiologies, and failure to optimize within 6 months. Really a guide in terms of when we should refer for advanced therapies or is aimed at helping us provide options for patients with HFrEF with different therapies that are listed on the right. And then Ted had talked about patient assistance is so important, and it can be such a barrier for our patients. This is a nice website under WebMD with some different options to think about how we can get medications to patients that may be out of the box. It does take time. It does take sometimes dedicated people that know how to do this and can do this on a regular basis, but this can really be additive when you're trying to get patients on multiple medications. And we know now that we have more medications, it's more complex than when we just had ACE, ARB, or beta blockers. And so really having this in place in the clinic is really important. Also important is having tools for patients. If you've not seen this CardioSmart tool about what I have, a reduced ejection fraction, heart failure, now what? This is a really, really nice comprehensive tool that includes lists of medications and what they're there for, what the names are, what to watch for. So if you've not seen this, I highly encourage this. There are other ways we can support patients. The Heart Failure Society has their heart failure storylines. There's Patient Connect, another app. I even found this really nice PDF for patients what to do with their heart failure medications if they're sick. like if they have diarrhea or whatnot. So I think however we can educate our patients along the way and engage them is really important. And it just speaks to the need for shared decision making. Also, another cardio smart tool. You may think that I work for the ACC, but I don't. I just find their tools to be really, really on point and helpful. This is a decision aid about an example of talking to patients about RAS inhibition and the benefits and how to maybe help make a decision about if this is right for your patient, and hopefully based on the evidence in the discussion, it will be. But it's really about partnering in the patient's care with them in this shared decision-making mode. So finally, I'd just like to wrap up with the criteria for graduation from the GDMT clinic. And that would really be when GDMT is maximized, when you've got stable vital signs and labs, when the patient is knowledgeable and engaged in their care, and then you've got a long-term GDMT plan. And it's referring them back to their usual provider, really even with a nice discharge summary that would include the reasons for referral, all the names of the medications and doses reached, any intolerances, their summary of New York Heart Association functional class and their labs, documenting how the patient is understanding what the plan is, long-term recommendations, and then recommendations for repeating imaging, and then consideration for devices should the EF not improve beyond usual targets. So here are my references, and I think if we've got time, we wanted to finish up the case presentation with Kathir. And you're still on mute, Kathir. I think, Kathir, we still have you on mute. Are you there? I wonder if he had to skip off for a minute. Huh. Well, let's see. So we've got a 38-year-old with family history of premature sudden cardiac death, and a father presented to urgent care with abdominal swelling, leg swelling and edema and dyspnea. Initially, we were concerned about liver disease and was started on aldactone and Lasix and referred for liver ultrasound and cardiac ultrasound, but the EF showed severely reduced ventricular function, EF 15% and dilated to 5.8 centimeters, and EKG showed normal QRS.
Hey, Kismet, sorry. Thank you. I'll take over. I apologize. So this was a patient. Okay. I apologize about that. This is a patient in our GDMT clinic run by our pharmacist here at Metro Health, Megan Valenti, who should be on the call as well. So she basically, this is the patient we found initially with the EF of 15%, dilated at 5.7 centimeters back in January 13th next. They first seen cardiologist 2 days later. Blood pressure is 112/62 and heart rate's 116. They were initiated on toprol as well as losartan. Their Daltone was reduced because initially they were on 50 milligrams. Thought process from a previous clinician was that this may be liver related. So they initiated on aldactone. Then he was referred to our GDMT clinic, which is pharmacy run. He had a cath done interim, which showed no CAD. Next. And then within a quick time span over on a weekly to bi-weekly basis, he had increases beta blocker. Next. Transition to Entresto from his losartan and then started on Farxiga. Next. And then increased the toprol. Next. And then had an MRI, which already showed improvement in his EF in February, which is about a month into his medication titration, and the ventricle is not as dilated now. Increased beta blocker further. Next. And then attempted Entresto again at a higher dose, but wasn't able to tolerate. So this was considered target therapy. And then eventually was discharged on quadruple therapy with Farxiga 10, metoprolol XL 100 twice a day, and Entresto 24/26 twice a day, and aldactone 25 once a day. And he did very well. And currently his EF is now up to 55%, and he has never been hospitalized. And so he is doing great. and has been discharged from our GDMT clinic within 3 months, in comparison to our first case, where even despite a whole year, he was not escalated. So I think that we have lovely cases like this in all of GDMT clinics that I've talked through. So I think this is hopefully highlights again the importance of it. And so thank you again for the opportunity to have this conversation. All right, great.
All right, well, thank you guys. Wonderful. I'm gonna stop the sharing. So I would like to offer this opportunity for anybody in our group here who has any questions. I know we've got a number of people on the call who work in our disease management program, or if anybody else out there has anything that they would like to ask any of our panelists, please just go ahead and unmute yourself and you can ask your question.
Hi, my name is Bethany. I'm one of the nurse practitioners in our clinic. I was really impressed with how fast you were able to do titrations in your example. Were you doing telehealth visits, in-person visits, or both?
So in this particular case, these were all in person. And then there were some intermittent, because once we provided a blood pressure monitor and a weight scale, there was a handful of telehealth visits as well. And initial education with expectation really helped for the patient to understand what the target doses were. So they were very motivated to reach those targets.
Yeah, I would just piggyback off of what Kathir said too. It just depends on I feel like the patient you're working with too. Obviously, if you have a younger patient that's busier with work and kids, it can be harder to kind of fit this in, especially with in-person, even telehealth. But from what we've found being exclusively telehealth compared to kind of just our baseline, looking at kind of placebo patients that are managed in our clinics, patients are easily able to fit things in from a telehealth standpoint, especially if it's just 15 to 20 minutes. You review vitals with them, make sure blood pressures aren't too low, heart rates make sense. It's much easier to titrate over telehealth than obviously in person. And a lot of, especially at academic medical centers, you have patients that are coming from potentially farther distance or more remote places that are kind of funneling into our systems, especially depending on where you have clinic locations at and so forth, and where your GDMT clinic providers would be at. But I think if you can do it, telehealth is definitely the most efficient way, and it allows you to see these people more frequently, and they can fit into their schedule more frequently too.
Yeah, I would add and agree with what has been said. I think the ability to see some patients in clinic, some patients via telehealth, virtual visits, the combination of that it's really great to have that option.
Hi, this is Brianne. I'm the pharmacist for the DM clinic with Yale. I was just wondering if you guys check labs routinely as part of that titration. I feel like typically like patients not getting their labs checked is what prevents us from increasing it as fast as your example shows.
Yeah,
I guess,
always. Oh, go ahead, Ted.
I was just going to say, so I think in the paper you'll find kind of what we recommend for labs. I know at least here at the University of Wisconsin, so we have delegation protocol where I can order whatever labs I need to related to titration. So we've kind of predefined exactly when we want labs drawn, depending on what medications we're up titrating and how often. So I think kind of coming up with some sort of a system that makes it easy for the clinician to do that without having to jump through hoops and ladders, especially for pharmacists or potentially nurses if they have to get APP or MD or DO sign off.
We'll typically order a BMP for the day before a patient has a virtual visit, but certainly follow kind of our protocol where if we add or change the dose of ACE, ARB, or ARNI, we get a BMP within about a week. We also created kind of a Spiro labs where anytime we start an MRA, we have a plan for getting labs within the first few days, and then a week later, and then monthly, and then quarterly. So we really are following those pretty closely.
Yeah, so when it comes to RAS inhibition, we get labs, but if it's for their beta blocker, oftentimes that can be titrated without labs in telehealth.
There was a question, I think, just to me in the chat about the difficulty of adding on a GDMT clinic to the existing heart failure clinic. I think that's, we have actually at Intermountain a specific GDMT clinic. We have our advanced heart failure clinic, and we're doing, GDMT titration within our APP panels. I think that, it speaks to the need for having a real strong operational administrative support structure, so that you could really define what it looks like and how separate it would be with an existing heart failure clinic. If you would run it certain days, if you would run certain providers or nurses, APPs, pharmacists that would run it. As long, I think it's definitely doable. It's just a matter of being really clear in terms of who's doing what, when, and how you want to track the results of your clinic.
To piggyback off that, Kismet, I think a lot of places are already doing this, like you said, and they're having nurses that are titrating these things telephonically with patients, and it's just not operationalized or kind of formalized in the sense of a GDMT clinic. But yeah, I would agree too. It's just leveraging resources and having a strong, supportive. If you have a strong physician champion, I think that's the biggest piece. It really goes a long way, especially when you're trying to make these arguments to whether it's, the head of the cardiology division or just the C-suite in general that's going to be funding these sorts of positions ultimately. But yeah, I think this stuff is being done all the time. It's already being done in heart failure clinics, but it's more or less trying to find a way to leverage some of the other healthcare providers on the team in a way that they can offload, especially their physician and APP counterparts, to focus on some of the more the higher level things in terms of diagnostic work and the management of more advanced patients, where we can really just focus on the GDMT aspect for these folks. They still need to be seen regularly and have hands put on them. But if you can find a way to really focus in on just the GDMT aspect, like the case that Kathir pointed out, you can really do a lot pretty quickly if you're able to kind of mobilize and operationalize your resources.
I see Adrian's unmuted himself. So Adrian, go ahead.
Yes. Thank you for your presentation. It's very interesting. Now, I've got a question about how you guys achieved the buy-in from the different providers, different services. Here at Yale, we've got some, I would say, additional challenges compared to other settings. In our hospital, we've got multiple private practices in addition to the academic practice or team employed by the hospital and university itself. So in a setting like this, have you guys implemented programs like the one you're describing? And how would you guys achieve the buy-in from these different teams that are private practice that could see a program like this like a potential competitor, someone that could be taking the patients that they would prefer to keep themselves?
That's such a good question. And I think if you can point out the benefits, GDMT titration, somebody needs to be kind of connecting with the patient to see how they're tolerating it and prescribing the meds every week to 2 weeks and following labs and vital signs. And a lot of general cardiologists or others, interventional, they're so busy to be able to do that kind of hands-on time commit with a patient. A patient would be a barrier. So offloading them and saying, if you send your patients to us, we'll do the GDMT titration, send the patient back to you for any imaging, any issues, and we'll do the education, we'll adjust the meds. I think that might be one way to go about it. Clearly it is at times challenging when, you're talking about referring a patient outside of kind of usual referral patterns. But I think that there are definite benefits to offloading busy teams in terms of being able to do this kind of time-specific work with patients.
So what
sorry,
we
go ahead.
did at Wisconsin is we, I think you have to be a realist sometimes and realize that no matter what's in the best interest of the patient, sometimes some people don't care. And a lot of it comes down to money and the ability to bill for seeing those patients. So I get that side of the argument, but to make things easier for us, essentially part of the enrollment criteria for our patients was they needed to have a PCP or a cardiologist that they were seeing that was within the University of Wisconsin health system. So that way we weren't trying to compete with what someone else at a different health system, because we see, like you guys, you see so many patients that get funneled in from all over the place. And, it's impossible to communicate with some of these different other providers. And a lot of the other providers just aren't aware of kind of the scope of services that we're able to offer those patients. So just to simplify things, we ultimately just made the decision to only enroll patients that were followed by our providers in primary care clinics and then also our cardiology clinics. But yeah, I think it's a great point and a great question. I think Kismet did a good job of kind of highlighting, the appeal to the emotion. But I think, at some point, sometimes you just realize, no matter how much you appeal to emotion, it might not get anywhere.
Emotion and practical, operational ability to, throughput of patients through clinic. It is time consuming.
So I'd like to add, coming from Connecticut, and I know I think Michelle is on the phone previously from St. Francis. So I was with this experience at that institution where we had probably 6 or 7 private groups. And as a sole heart failure clinic at that location, we would have tons of patients usually funneled through, but there would be that hesitancy to send patients to this clinic in its infancy because of that concern of having their patients taken, in essence, and reduced billing opportunities and so forth. And so what the interventions included, first off, was we had pamphlets pretty much given by non-physician providers. One, to be honest, it was less threatening in the sense that we weren't having provider MDs taking their patients, and that helped. And the second one was having patients sent through our clinic and seeing the effect of these patients through the GDMT clinic, and then telling the provider, who is their primary cardiologist, this is what we've done. And oftentimes that one case was enough for them to realize, oh, I see the benefit. And it took a lot of legwork to get the trust of a lot of providers, but oftentimes one champion within each private group was what it took to get convinced, and then word of mouth spread, and then the census did rise. And so it was a very cumbersome process, but it worked with persistence and a lot of initiative on our part to get the patient sent over, show the effect of the benefits of these medicines in our clinic in an expedited fashion, and then show the proof of concept to the providers. I think that's how we did it.
Yeah, just to add one more point, I'd say for us too, even though we didn't take people outside of our health system, even to reduce friction amongst internal providers, family practice doctors, internal medicine physicians, cardiologists, we had to go and we literally, many meetings would just present this information to those divisions at various meetings and just kind of educate them about what our plans were. So we had a great buy-in from our head of advanced heart failure, and then also our inpatient head of general cardiology. So it made the arguments easier, but it's, I think we found that just early communication and communicating often with these different groups really helped to educate them in terms of what we were doing. So that way we didn't have any friction with any of these providers as we transitioned these patients in the ambulatory setting. Everyone was very welcoming and receptive. And in the Midwest, people are just, it's Wisconsin, so people are very nice and friendly. There's not a lot of arguing.
And one more thing to add, if there's ever a heart failure consult, we always utilize those to our benefit, because a lot of these private attendings would be rotating. And as soon as they got a heart failure consult, we knew immediately that was an opportunity to start the education up front, even if it wasn't for a consult for a GDMT titration. So that really was a signal for us to take that opportunity.
Do you guys advertise this service directly to the patient? Like, for example, you were seeing a patient for whatever reason, and would you bring up, oh, by the way, we've got these clinics in which we can help you with this, so that they would circle back to their physicians and express their interest?
So that's a great question. So we never did that initially because of the trust aspect. Again, for it's almost like when they see an ad on TV and they go back to their clinician. Sometimes the clinician may take it wrong. Like, well, where'd you get this information from? So we did not do that in the infancy of this, just because of the risk of that.
I had one question, but I would like to allow anybody else, if they would have a question, to take the time before me. But if not, I can wrap it up with my last one, maybe. So I'm not seeing anybody unmute themselves. So Ted, I want to go back to something that you had said during your part of the presentation, which I think was interesting in understanding some of the barriers and challenges that I've seen, at least in our efforts here locally to run a similar type of program, with this idea of automatic referrals, either through hospital discharge or outpatient encounters, and having it more as almost like an opt-out type thing where, this is going to happen. These people are going to get referred to the clinics. If the primary doesn't want them to, they can take that effort to say no, but it's going to be automatically done. I guess, where did the political willpower come for that? Where did the administrative support come for that? Because I think that would be a wonderful tool that I think we would get a lot of benefit from. But I know there would be a lot of concern. Again, and I completely agree with the statement you made about sometimes we want to do the best thing, but not everybody's always on that same page as well regarding patient care. So I guess, how did you guys get that through and working in your system?
Yeah, so like you said, I think a lot of it's institutional dynamics. I'm lucky to work here where I've never been somewhere where it's pretty frictionless when you're trying to do things to improve the quality of care for patients, and everyone is usually on board. So I think this is a rare place in that sense from other places I've trained to, where any ideas like this would take a lot of vetting and a lot of just elbow grease to really convince some of the powers that be. I think what helped us a little bit was we had run a pilot. So that's where we got started. Again, we went and talked to all of these different divisions. So not only inpatient folks, but also the outpatient providers. So making sure that all of our family practice docs, our internal medicine docs, and our general cardiologists that were seeing patients both in and outpatient were aware of what we were doing, and that they could kind of address any concerns that they have. I think the thing that made it easiest for us is that ultimately, if our pharmacy and therapeutics committee agreed that this was the best approach, which is comprised of a majority of physicians and then some pharmacists as well, that was that's the letter of the law at our institution. So there's not really a lot of arguing with that. Now we had and I'm happy to share our inclusion criteria, essentially what we had from the inpatient side, because we only enroll on the inpatient side, but we would have an auto-generated report on a daily basis that would tell us who is hospitalized with HFpEF or HFrEF, give us pertinent information. We'd go in, make sure they don't meet any exclusion criteria. The pharmacist, because ours was just a pharmacist-run GDMT clinic, would then go and meet with the patient, see if they were agreeable to enrolling. And then at that point, if they were, there was an order that we would put in within Epic that then auto-enrolled them in this clinic, and it auto-generated a message to any provider that cared for them within the UW health system. So our IT folks were really helpful. But, we had a few folks that reached out and, again, were asking a little bit more about what we plan to do and how often we plan to see them, in which case, I talked to some of them on the phone. Others were just happy kind of rereading the protocol, which they weren't aware of. But it's tricky depending on the institution and so forth. I know some, depending on what part of the country you're in or just the institutional landscape, there's a lot of again, friction towards these sorts of services. And I get it, it's something new, and it's tough to develop that level of trust, especially with clinicians that some providers aren't used to working with in these capacities. So I think, if you can take it slow and build it, and, especially from the pharmacy standpoint, we used or leveraged our residency program to help us get this off the ground, demonstrate that it could be successful. And then once we had done a small pilot with very few patients, kind of demonstrating the safety of it, that also was helpful. But again, having the head of heart failure, our head of heart failure, and head of our inpatient cardiology groups on board, I really kind of sealed the deal. Without them, I think it would have been a difficult argument. So,
is your institution hiring?
We actually are looking for 2 pharmacists in our lung and heart transplant clinic. So if you know anyone, have them email me.
That sounds like a really nice environment.
Yes, it is unique to be somewhere where everyone is very friendly. I wasn't used to it at first, so I thought something was wrong here.
It's Midwestern hospitality.
Yes.
You wonder too about the kind of the quality improvement approach in terms of, we've got all of this baseline data about how under utilizing we are, across the country or maybe world of GDMT, and maybe if you can get some local statistics too, in terms of where you are, that would add into, what we've learned about, the gaps in GDMT prescription, and say, let's all get in this together. If you've got a culture of pilots and quality improvement and having local baseline metrics, and say, let's try this. And I think what Ted said about having, real strong, not only administrative, but physician leadership to say, yeah, this is such an important idea. We have a big gap, we have a big need, and we can do better. All of us, this is everywhere. And let's try this, and let's see if we can get it to work. And clearly, we've got pilot data, institutions that are doing this, that are making a difference. So, you wonder if that would be a strategy as well.
So Chris, you're not allowed to go look for a different job. Sorry.
Oh, come on.
So, well, thank you all. We set a record today for 2 things. One, having 3 presenters, and 2, we've gone 80 minutes, which is our longest talk of the year so far. But as you can see, it's been engaging, and a lot of people here sticking around for 80 minutes because this was a very important topic to a number of us. So thank you to all 3 of you for joining us. Hopefully one day we can see each other in person and continue to work on these really important things for our patients.
Thank you for the opportunity.
Thank you.
Bye-bye.
Really nice to meet you. Thanks.